Joining us from Wellington. Kia ora, Michael. Michael Baker is an infectious diseases epidemiologist with an extensive publication record on pandemics and related research. And his talk will focus on understanding, my apologies, his talk will focus on the COVID-19 elimination strategy, why it was the best choice for New Zealand. Thank you, Michael.
Yeah, kia ora koutou, and thank you very much for inviting me to contribute to this really great webinar series. And so as you've heard, I'm going to talk about the elimination strategy New Zealand's adopted, and I think I'm going to pick up on some of the themes that Philip and Joe have already introduced very effectively. And again, this is work that draws on activities by a number of my collaborators who are listed here. So this is one of many images that are circulating around. I think this shows, I guess, a view from New Zealand about the success of our Indigenous approach, which is still unique. We are the only country in the world, as far as I know, that has actually published an elimination strategy, although many other countries, particularly in the Asian region, have pursued containment and heading towards elimination as well. So I'm going to briefly talk about some of the strategic choices that are available, mitigation versus elimination, and the major components of this strategy, what effect it's had, and how we actually continue to maintain elimination. And that's obviously very topical now that we're really in this post-elimination world, which is very new for all of us. So when we think about how do countries choose what they're going to do, and by definition, emerging infectious diseases are things we don't know much about. And we've got a range of factors we think about that shape our response. Obviously, we think about the impact, particularly case fatality risk, impact on inequalities, transmissibility of the pathogen, that affects also how easy it is to control it. And we have to make decisions in the absence of information. And this is often quite terrifying for scientists because we like to be very certain about the advice we give. But we're also influenced by our own experience and dogma as well. And we have to think about the feasibility of the response and the economics. And this is often where the science hits other constraints and where politicians have to, in the end, make the really tough calls. So one of the, and Philip Hill's already talked about this, one of the key factors is mortality. And with my colleague, Nick Wilson and others, we did the modelling for the Ministry of Health in February that informed the decision-making that New Zealand made. And this suggested that these are the kind of fatalities you might expect if you had a wave of COVID-19 infection in New Zealand with only a small amount of constraints. So obviously this is a large disease burden. We explained it as equivalent of 25 seasonal influenza seasons. The other factor that I think is very important in New Zealand is inequalities, and Joe Baxter has explained this very well, that New Zealand has a really terrible legacy of inequalities with both what we say ongoing endemic infections as well as pandemics. And this is looking at 3 influenza pandemics, right up even to what we'd say is recent times. We still have marked ethnic inequalities in mortality. And that's only one of many indicators of inequity. So the choices that countries had, well, right up until mid-March, New Zealand was heading down the mitigation path. We had our pandemic influenza plan. It's got this line that we heard a lot about, flatten the curve. And that was the path we were going down. We're going to keep it out for a while, stamp it out, manage it, and manage it post-peak. So this is based on the fact that you cannot exclude an influenza pandemic. The incubation period is short. There's a very high proportion of asymptomatic people. So with my colleagues, we started to promote an alternative view, elimination, And this was partly based on the experience of China in terms of its ability, its success in containing this pandemic. And as we know, elimination, it's got a long track record with infectious diseases. It's been around, the terminology, about 30 years. You can eliminate some diseases at a country level or regional level, and you can aim to eradicate them at a global level. And the approach here is really you're stopping the curve. You're not flattening it anymore. And New Zealand switched very dramatically to this approach when the Prime Minister announced on the 23rd of March that we are rapidly going to a very high alert level, level 4, which was effectively a lockdown. So with the elimination strategy, you've just got these 3 fairly blunt instruments: excluding cases at the border, case and outbreak management, so testing, contact tracing, then isolation and quarantine, and then reducing transmission. And there are, again, very limited tools here. You can reduce transmission through contact, which is about hygiene measures, or you can reduce the frequency of contact, so physical distancing and so on. We actually, I should say, we wrote up this approach in the New Zealand Medical Journal and also now in the Medical Journal of Australia. So going through those responses, I think almost everyone who's lived through the last few months will almost know this strategy anyway, that we have border management, initially entry restrictions. Our border's never been closed, although there were remarkable days when no one came or arrived in New Zealand or left the country. No one could remember when that last occurred, but it was decades ago. But most days we have about 300 people arriving in New Zealand on average. So you've got these components, initially self-isolation, then moving to supervised and managed approaches, and also extending these practices to aircrew and seaports. And as we're finding, it's hard to do this at a big scale consistently with no mistakes. So that's the challenge we're having to manage at the moment. And there was a succession of measures here. These are only some of the large ones. There's been lots of key dates here where it's been fine-tuned. And we have these amazing scenes at airports with virtually no aircraft coming or going. So case and contact management, this of course is a new strategy to build up. It relies initially on really establishing testing for a new pathogen, increasing that capacity, having assessment places, contact tracing, and everything associated with that. We've still got very limited digital assistance with this. And again, there was a succession of key dates here as this national capacity was increased. And again, if you look on the ministry website, you'll see a graph like this. It's updated, but it shows just the massive scale of this operation. And certainly New Zealand is amongst at the high end now of countries in terms of testing rates. So the third strategy about reducing transmission, it all comes down to reducing this reproduction number, which I guess has become almost a household term now. And if you look at the reproduction number, it actually has 3 components that feed into it. So the risk of transmission per contact, the contact rate, and the duration of infectivity. Now, unfortunately, we can't modify this one, duration of infectivity, at the moment, because we need antivirals to do that, which we don't have. But transmissibility is around physical distancing, cough etiquette, and mask use, hand hygiene, and so on. Contact rates is really, if you encourage everyone to go home and stay home quarantine, that's very good at reducing your contact rates. And obviously mass gatherings and so on are bad for contact rates. So we're again familiar with the alert level. Sorry, this is not really readable, but this was actually delivered to everyone in New Zealand. And I think it was a great risk communication tool, which was adapted by similar tools being used overseas. And again, the entire country became very focused on what alert level we were at, understandably, because they had huge implications for many of our day-to-day activities. Reducing contact, transmission per contact, again, you've got limited range of options here. And one that New Zealand does not have, which is really puts us out of step now, I think, with many countries, is we don't have a culture of using face masks, and sometimes the terms used mass masking or universal masking, and this is particularly the use of reusable fabric face masks by the public. I mean, it's not, for instance, on any of the posters that were produced in New Zealand. So we're told to hand wash, but the limitations of hand washing is that it doesn't really help you much when you're on a bus and someone's just talking with you, breathing on you. Even worse, if they laugh or sing or shout, they can infect you in that pre-symptomatic stage. So the physical distancing, that's the other part of this. Again, this was very clear to everyone, particularly at level 4, that you essentially, the whole country put into home quarantine for almost 5 weeks, and even at level 3, something fairly approaching home quarantine. We saw these remarkable scenes across our cities. For many of us who are fortunate, and I think most university staff were very fortunate that working from home is manageable. Unfortunately, it's very tough for many other people. But I know getting on my bicycle and cycling around Wellington, which I do usually regularly, was just such a blissful experience, minus the motor cars. And we saw other various expressions of physical distancing and really this communication to the whole country about what was involved. So there's a very busy slide here, but it is just showing that there's a whole sequence of dates, but the most dramatic ones, of course, were moving rapidly into level 4. And that was really the thing that distinguished New Zealand's response from many other countries, was that and it's a distinguishing feature of an elimination approach, is that you throw maximum activities or resources at containing transmission at the start. When we had only 100 cases when the decision was made and no fatalities at that point. Whereas the influenza plan says you basically increase these controls as the pandemic gets worse to flatten the curve. Excuse me. So what was the impact of that? Well, we don't know the impact of all the components, but we can look with modelling at the effects of the lockdown, and we can see that at alert level 4, the effective reproduction number was under 0.5, and that obviously means that chains of transmission on average will peter out, and that was compared with the reproduction number before that of almost 2. This is another approach to modelling this. This is using, I think, very clever phylogenetic approaches by colleagues at Auckland University. And this is showing a very similar result, that prior to these lockdown measures, each case in New Zealand was typically infecting 2 or more cases. So we had basically that's exponential spread. And during the lockdown period, the reproduction number again was under 0.5, and similar to what was achieved in Australia and also in Iceland. So with an elimination strategy, there's a question, of course, of what does elimination actually look like? I mean, how do you know that you've actually got there? And this is a definition that we put up, and we do a lot of scientific blogs during this period. And you've got these 3 elements. You've got no detected cases for a period, and I think 28 days gives a high level of certainty in the presence of a high-performing surveillance system, and also excluding cases that are not local transmission. For example, those that are identified at the borders and placed in effective isolation or quarantine. And we can see the problem of not, at the moment, to the world, it looks like New Zealand has ongoing transmission, because our daily total is including 1 or 2 cases at the moment. And that's, it's really not particularly sensible to have all of these cases put together, because these do not compromise our elimination status, as long as they stay in effective quarantine, of course, and not released early to infect people. But if they don't infect people in New Zealand, that doesn't alter our elimination status. So why does all this matter? This is really showing the different options that countries have. And sorry, this is a very busy slide, but we've got these stark choices. You've got an exclusion strategy, which is adopted by Pacific Islands, and we can see examples, Samoa and Tonga have excluded the virus entirely for good reason. And an elimination strategy is really what New Zealand's doing. We followed the example of really mainland China and Taiwan. They had a lot of experience with SARS, but this has also been pursued by Fiji successfully. Suppression strategy is that and this is obviously most of Europe and North America, I'm not sure how to classify them, but this is where you are trying to minimize the number of cases in the community, but you're not eliminating the virus. Our mitigation strategy was talked about early on by a number of countries that was based on certain assumptions that turned out not to be very valid. I'm not sure if Sweden would still describe their approach as mitigation. And unfortunately, for some low-income countries, there's really no substantive strategy. And it's interesting to think the end path here, exit path, is to emerge, as New Zealand has, into essentially a country that has no ongoing transmission before the benefits come from that. I think the difficulty with suppression is that you have ongoing transmission and you may be going in and out of lockdown. So I'm not, I haven't done a detailed analysis of the consequences of this. I mean, we all, I guess many of us are looking from time to time at the quite depressing global statistics. But when you look at cases that are in this elimination or exclusion group, and sorry about the very busy slide here, but you can see typically these countries have very low mortality rate as expressed as deaths per million, say. And obviously you don't want to focus on the details here, but the broad pattern is even in very populous countries, like as we've heard already from Philip Hill, China has this very low mortality, just in a very similar range to New Zealand and Australia and Singapore. I mean, really the world leader is Taiwan, who did everything right from the beginning, and I think we can learn a lot from their experience. Suppression is, again, has a wide range of levels of success. Some countries have suppressed the virus very effectively. Other countries, it's quite grim. If you look at 0.15% of the population in New York has died from this infection. And we imagine what that looks like if it's applied to all of the United States. They might have 500,000 fatalities. So the pandemic's got a long way to run virtually everywhere. And there's some estimates that it's only infected maybe 5% of the world's population at this stage. So it's got the potential to cause 20 to 30 million deaths globally. I'm not sure for any countries that are really in a mitigation approach, but with the Swedish example here has not been successful. So what are the ongoing challenges going ahead? We've got threats to elimination in New Zealand, obviously failures of border management.
I didn't get that.
We've got increasing transmission in winter and problems with resuming large indoor social gatherings. I mean, this is the calculated risk of staying in level 1. Wider health threats, we've heard about the indirect health effects of the response, increasing economic hardship and inequalities, and some of the multiple global health consequences of this ongoing pandemic. So what do we have to do to maintain our status? Well, I guess obviously careful border management. We think we need a culture of face mask use. At the very least, we think all New Zealanders should have a reusable face mask and know how to use it if needed. And there's some really clever technology which can improve contact tracing. And we're advocating very strongly for a rapid review of our progress so far and establishment of a dedicated National Public Health Agency to manage the response going ahead. And unfortunately, the Simpson report, the review of the health and disability system, says virtually nothing about health protection. It's just, it doesn't pass the COVID test. And even regardless of that, it really has virtually nothing on, I would say, many population health goals. It's really about reforming the healthcare system. And that's good, but we need a separate focus on this area. So I think these are some of the main points from this, I think, and lessons that we really need a very effective risk assessment and strategic decision-making in public health crises. I think the combination of good science and good leadership is really vital. I think there's a strong message, I think, for the whole country will have seen how we need to increase or invest in our public health infrastructure, and also at a global level to reform the World Health Organization. And hopefully this is an opportunity for a broad reset because the kind of approaches used in this pandemic can hopefully be applied to the many other global health threats that are already upon us, particularly related to climate change. So one of the truisms of public health is that if everything goes perfectly, no one notices. And this is a cartoon I was sent. But how will we know if our pandemic guidelines work? The world will think we overreacted. And I think we all experienced versions of this when we've discussed the pandemic and what to do about it. Thank you.
Thank you, Professor Michael Baker. We do have a few questions, and I will read them in the order that they came in. Firstly, could you talk about testing technology and any likely advancements that we might expect here, for example, saliva tests or improved result speeds?
Yeah, I'm probably the wrong person to ask about that, but certainly the thing that's really impressed me is the speed with which our laboratory scientists have all got together and really pulled together a remarkable increase in capacity across the country. And that I think has just been vital to the response. I know going ahead, there's a huge number of different testing technologies that people are working on, including our scientists at Otago, and they do offer rapid, rapid testing is a whole lot of rapid testing technologies that are being looked at. At the moment, I think we're still very much with the using the standard PCR methods that do have, they're highly sensitive if the right specimen is collected. That's obviously a limitation, but and they do take some time. So I know there's advances happening in those areas.
Thank you. Next question. What is your confidence in New Zealand's current surveillance and contact tracing system?
Well, I think the core elements are very good. I mean, that's basically about information systems, protocols, a trained workforce, and experience with doing this. And one of the interesting things now, of course, is that this system is, it's in theory got the capacity to follow up to 1,000 cases a day, which is pretty remarkable. So it hasn't really been, if you like, tested rigorously yet. That's certainly not at that scale, but I understand they are doing exercises to simulate what would happen if there was an outbreak. And we'll need to keep doing that because the hope is we don't have any cases or outbreaks in the community in New Zealand.
Next one. Why did you say you're not sure how to categorize the Americas with their strategy?
Well, obviously, the United States, I don't even know if you'd call that a suppression strategy there when they're opening up the country very early. And if you have widespread cases in a population and you lift the constraints on physical distancing, you appear to actively discourage mask use, then that's a complete disaster. And all of those cases you've got in the community will all start outbreaks with a very high reproduction number. And one of my colleagues does a lot of modeling across the globe, and he sends me these analyses which are right down to the state level in the US. And it really is very disturbing because you know what will happen in 1 or 2 incubation periods from now. There will be these explosive outbreaks in all those states that are not following basic measures. So it's a disaster.
Thank you. You mentioned that Aotearoa's approach changed from a mitigation to an elimination strategy sharply on March 23rd. Do you have an opinion on why the approach changed so sharply and why at that point?
Well, this will be something that will be analysed in fine detail, I'm sure, in the future. There was a cabinet COVID committee that was, I think, making the final call, and that's why I think we have politicians, because they have to make these the kind of decisions that are very tough to make, because the idea of shutting down essentially the whole country is very tough, and you know it's going to hurt people and people will lose their jobs and so on. But at the same time, you're balancing against public health, and I think that's a real tribute to our government, that they prioritise public health. But actually it's be a false dichotomy to say one or the other, because I think they do go hand in hand, and I think our government did recognise that. I mean, obviously there were public health people like myself, that switched to saying we absolutely have to follow this elimination path, and were saying it very publicly in the days before then. And interestingly, the business leaders in New Zealand were also saying that. And that's because many of them had operations overseas, and they could just see how gruesome things were becoming. And they had, I think, a Lifeboat New Zealand viewpoint that we had to save the country, and they thought that was the most viable approach. Because after all, it's the least bad option. And this is the whole realm of counterfactuals. When people say, oh, elimination is really tough, of course it's tough, but you have to say, what is your alternative? And I think there was that realization the alternatives were much worse than elimination at that point.
Our next question says, elimination is a great achievement. What are the implications if SARS-CoV-2 continues to be endemic elsewhere in the world, which seems likely, and available vaccines are only moderately effective and or uptake is modest?
Yeah, look, that's a great question, because we just don't know about the duration of immunity. There are many unknowns, but at least New Zealand is in a position to make an informed choice, hopefully, and in the form and the time that we can choose. So in other words, we're now in control of the pandemic in this country. We're not having to trail after it. And I think that's a really good position to be in. And also, I think the other therapeutic options may be very good antivirals, which could turn this into a treatable form of pneumonia. As is the case for many forms of pneumonia, we don't have vaccines against many infectious diseases, but we manage them with antibacterials and antivirals. So I think they're the other options that will also help.
Thank you. What should Air New Zealand be doing re international aircrew? I.e., should they be travelling home on domestic flights directly following an international flight?
Well, yeah, I agree. There's lots of concerns about air crews, and also at seaports, that we have to plug all these potential holes. And I always think that anyone who thinks is proposing an alternative to 14 days quarantine in a supervised facility needs to explain why what they're proposing is giving an equivalent level of protection for New Zealand. I think it is possible to do things that work as well, but I think these business enterprises like Air New Zealand need to justify that it will achieve a similar level of protection.
And is there any point in history that herd immunity has actually worked?
Well, yes, for many infectious diseases, that's all we had. Before we had vaccines, we had herd immunity for many things. I mean, you think of all the infectious diseases of childhood, measles, mumps, rubella, that's how people gain protection. But the price was that many children died. And of course, indigenous populations who were exposed to these infections as adults, they were particularly lethal. I mean, measles and smallpox basically killed almost everyone in the New World at different times historically. So that's what the scenario we've got with with every emerging infectious disease. This is what we're confronted with.
Do you believe that the government is doing enough to monitor the impacts of COVID-19 on non-COVID-19 related health issues?
No, but I think there's a huge awareness of these other consequences. I just look at, I know some of my colleagues working on cancer control are very concerned about delays in routine screening and so on. So I'd say there's a higher level of awareness about these consequences, but I don't think we can quantify all of these consequences, but that is an important priority, I think.
The phrase whole of government response has come up a lot in the discussion about international responses. Does that help explain different approaches or different outcomes of the same approaches applied in different countries or other?
No, I think, and I've been talking with my colleagues in lots of jurisdictions overseas, and I think in the Western world there's been a terrible failure of risk assessment and risk management with this pandemic. And to quote, I think, the editor of The Lancet, he described this as complacent exceptionalism, that somehow the Western world, our science agencies over there, watched the pandemic coming out of China and said, we'll just treat this like influenza, almost imagining that it would not be particularly severe. And I think that's quite a shocking error of judgment. And I know in New Zealand we were looking for leadership from the World Health Organization, CDC in the US, Public Health England, European Centre for Disease Control. And I think the advice was poor. I mean, the WHO was saying, keep your borders open and don't use face masks as a population strategy until very recently. So I think they were really problematic advice we got. And I think New Zealand really made the right decision at the very last moment, just as the pandemic was switching from being predominantly in travellers to community transmission.
What should be the criteria for relaxing border closures if the virus remains endemic elsewhere in the world?
Well, I think one of the positives is that many countries in the Eastern Hemisphere are doing what New Zealand's doing. You've got, in China, 1.4 billion people largely protected. I mean, they will get the occasional outbreak. Taiwan, 23 million people, under 10 deaths. You've now got, even Vietnam and Mongolia have largely prevented fatalities from this. And so you've got a lot of other countries that we can start to interact with. Some of our largest markets, China and Australia, are largely free of this virus. So I think there's a very optimistic future for countries pursuing elimination. And we won't have to just stay sitting in New Zealand long term. I think there will be potential for even quarantine-free travel at some point.
Fiji's Prime Minister named you as an advisor to the Fiji health authorities as he relaxed restrictions in Fiji last night. What are your thoughts on the adoption of the Bula bubble concept, which appears to be used in more economic than a health context?
Yes, well, I think Fiji has done a fantastic job, and I mean, they've, unlike some of the other Pacific islands, they did get cases and then they stamped them out. So they are very much on par with New Zealand. They've done an elimination strategy. Arguably, they've done better. They've had no fatalities. So I'm actually very wary of making comparisons between countries based on these very crude metrics. But certainly, I think we should congratulate them on that. And I think we should do everything we can to establish travel links. Maybe Fiji will take a bit longer, but certainly Pacific countries that have entirely excluded this virus, there can't be any, I don't know why we don't have open travel now with Cook Islands, Samoa and Tonga, for example.
And we've got time for one last question. Does the New Zealand healthcare system and Western health systems in general need to reorient itself to management of communicable versus NCDs? A major problem at the hospital level was a lack of building design for infection control, for example.
Yeah, I think it's a very good point that overall the burden of infectious diseases has declined steadily, and I think that's a huge tribute to public health largely, better water, cleaner water and food and immunisation and so on. But the evidence now is that there are a growing number of infectious disease threats, not just from pandemic infections, but also bioengineered threats and antimicrobial resistance. So I think unfortunately, we've got the two major threats, NCDs and infectious diseases. We have to basically manage both of them going ahead. And I think it is a pity that the Health and Disability System Review, which was a huge undertaking, really doesn't have anything in it for managing these threats. So I think that's something that will need a separate agency, I believe, to take it forward.
Thank you, Professor Michael Baker. And unfortunately, we're out of time on our webinars for today. But I hope everybody will join us again from 12 p.m. We will be here from 12 p.m. to 1:30 tomorrow. And also, of course, live streaming on Facebook. Thanks very much, everyone. Ngā mihi.